I'm Dr. Kotak. I'm an FY2 equivalent. I'm a gateway doctor, so that means that I'm equivalent to the foundation year doctors, but I'm on a slightly different pathway, and that is to get my CREST certificate signed off, which is Certificate for Readiness of Specialty Training. And it's just basically signing off the same competencies as the foundation doctors and getting myself ready for specialty training. I did this because I graduated from Bulgaria, and for me, it was the route that seemed most appropriate for myself. I'm currently working in Birmingham Children's Hospital because I have an interest in pediatrics and family medicine. So enough about me, let's get started. So initially I thought I'd just do a little slide on the glomerulus because that is the focus of these renal diseases that I'll be talking about. So our glomerulus is the part of the nephron, is the first part of our nephron. So we have our mesangium here. And we have capillaries that come into the glomerulus. So capillaries are obviously lined with endothelial cells. And we also have epithelial cells with foot processes around them. Now, these foot processes have given them the name of podocytes. So the podocytes and the endothelium and the basement membrane all together make the glomerulus basement membrane. Now, this is basically like a filter. So if you think of a sieve, and everything coming out of the capillaries into this glomerular space and then into the proximal tubules is primary urine. So when there is damage that occurs to this basement membrane, these three layers that I mentioned, our sieve that we have becomes a bit more of a colander, and it has bigger gaps in it, bigger holes in it, and lets a lot more things through. So our glomerulus usually doesn't allow large proteins to be filtered through. It's usually smaller size proteins. However, when there's damage and our sieve has become a colander, these large proteins and other things are allowed to be filtered through and go into our urine. And this leads to some symptoms that we'll talk about. So let's start with Nephrotic syndrome with a big capital O, just to help us remember things. So let's define a syndrome first, because it just helps me when I'm learning something new to break it down into little definitions that then come together to make a clearer picture. So a syndrome is a collection of symptoms that occur together and that are associated with a specific condition. So where the definition of nephrotic syndrome is basically encapsulating the symptoms that we'll have, but the pathophysiology and causes of them and the management is slightly different for each cause. So the definition of nephrotic syndrome is it's a clinical syndrome that's defined by massive proteinuria, greater than 40 milligrams per meter squared per hour, and this leads to hypoalbuminemia. Hypoalbuminemia occurs because we're losing proteins and albumin faster than our liver can make it. So we have less albumin in our blood, and this then in turn leads to the loss of proteins, leads to hyperlipidemia, because if we think about our apolipoproteins, they help us carry our lipids around the blood, and if they're not there, then we're just going to have lipids floating around. So this is a hyperlipidemia. Our edema occurs because we don't have proteins in our blood, well, less proteins in our blood, and our proteins are usually there for the oncotic pressure to then bring all the interstitial fluids back into our vascular system. So if there's no oncotic pressure, the blood that's gone into our intercellular space, there's no pressure to bring it back into the vessels, so it just stays in this interstitial space, and this causes our edema. And there are other complications that occur with nephrotic syndrome, and this is also due to the loss of proteins, but I'll talk about that in a short while. So the reason I had the capital O is to highlight that nephrotic syndrome is a syndrome that involves edema, oedema, proteinuria, and hypoalbuminemia. So if you remember the O, remember these three things, and that should kind of take you down your pathway of understanding nephrotic syndrome. So we have an increased permeability due to damage to the glomerular basement membrane. So why would this occur? So it could be primary due to a disease completely isolated to the kidneys, or it could be secondary due to some other kind of process going on in the body that has now taken its toll on the kidneys. So we have congenital infections, diabetes, because we know that diabetes leads to some end organ damages, and the kidneys being one of them. This is known as diabetic nephropathy. We have systemic lupus erythematosus, and this leads to lupus nephropathy, again with the proteins and autoantibodies that get deposited in the kidney's basement membrane. We have neoplasia, so any lymphoproliferative diseases can lead to this as well, and certain drug uses such as NSAIDs, and we also have amyloidosis. So I'll speak about these different types of nephrotic syndromes. So the first one I'll talk about is minimal change disease. So as the name suggests, there's very little change that occurs in the kidneys themselves, but it leads to nephrotic syndrome. So this is the most common type of nephrotic syndrome that will occur in the children. So if a child comes to you with edema, proteinuria, hypoalbuminemia, it is a presumptive diagnosis, and it's classed as minimal change disease until there is proof for it to be something else. So in terms of the pathophysiology of minimal change disease, we just have fusion of the podocytes, and there's some kind of immune dysfunction going on in the background, which is not very clear. But this disrupts our filtration barrier. Again, our sieve becomes our colander, and we have lots of loss of protein. And in children, it's the most common form of nephrotic syndrome. It also occurs in adults, due to excess NSAID use, lymphoproliferative disorders, or syphilis, but this is very, very rare. And it's usually managed with prednisolone. So another type of nephrotic syndrome that we have is called focal segmental glomerulosclerosis. So sclerosis is a word for scarring, and glomerular obviously being our glomerulus. So we have scarring of focal or segments of our glomerulus in the kidneys. So this can be primary, again, idiopathic, with circulating factors. Again, not much is known about these, but it can be, idiopathic primary, or it can be secondary. So if we have a process going on in our body, for example, if we're severely obese, or there's reflux nephropathy, there's damage that occurs to our kidneys with this. And the damage occurs in the glomerulus, and some of them then scar. The ones that scar shrink in size. However, if many glomerulus have shrunk and stopped working, others will have to take on that slack, and they become hypertrophic. So we have scarring and scarred glomeruli, and then we have hypertrophic glomeruli as well. So this is a diagnosis that is made histologically by renal biopsy, and of course our history and examination and things and other investigations that we'll do that I'll speak about later. But for this one specifically, it's a histological diagnosis, and you'll see focal areas of scarred glomeruli and areas of hypertrophic glomeruli. If this kind of nephrotic syndrome occurs in children, we then start looking for an underlying genetic cause. So again, if it's primary and we don't know what the cause for it is, we give them prednisolone, and plus or minus another immunosuppressive. If it's secondary, so if they're severely obese or there has been other damage to the kidney, we can treat the underlying cause, and this should help with the nephrotic syndrome that way. Is there any questions so far? No. Okay, then we have membranous nephropathy. So this is an autoimmune condition that occurs, and it is due to antigens attacking the filtration barrier. So things that this PLA2 receptor that is expressed on podocytes, our antibodies are made against these, and this causes damage to our filtration barrier. And there's a secondary cause, which again, NSAIDs, SLE, or viral hepatitis can then lead to nephrotic syndrome or prostate cancer. So this is membranous nephropathy because there's no cellular proliferation or damage going on, it's thickening of the basement membrane. So again, we will look for autoantibodies against these receptors that were mentioned, and we'll also do a renal biopsy to see the histopathological appearance of the kidneys to identify that it is ideally membranous nephropathy. Primary can be self-limiting. It can be nephrotic syndrome for a while, and then they kind of get over it. However, certain people are at higher risk of disease progression, and for these type of patients, we need to give them some kind of immunosuppression because they're not able to limit the disease themselves. So we're going to have to stop their immune system, dampen it, so that they can have no more nephrotic syndrome, no more nephropathy, no more autoantibodies attacking their glomerulus, and allow them to not have nephrotic syndrome. So then we go on to secondary. How do we treat secondary? So if it's been caused by NSAIDs, SLE, viral hepatitis, or cancer, we have to treat the underlying cause. And lastly, in nephrotic syndrome, we have renal amyloidosis. So amyloidosis is deposits of these different types of proteins in our body. So it can be AL. So we have idiosyncrasy of the heavy and light chain in immunoglobulins, and when we have excessive light chains, they become they're resistant to degradation and they become insoluble, and then they become deposited. A type of amyloidosis is due to chronic inflammation. So if there's a chronic inflammation going on in the background of the body, these can then get deposited into the glomerulus membrane as well, and this will lead to our symptoms of nephrotic syndrome. So this is also diagnosed by renal biopsy and Congo red staining specifically. But again, if there's a history of amyloidosis and we develop these symptoms, then you can kind of piece your picture together in that way. And again, we treat the underlying cause of the amyloidosis. So what do we see? So we've spoken a little bit about the clinical picture, but here's a nice little mnemonic that spells out nephrotic instead of nephrotic. It's nephrotic, and it is sodium retention, our Na, albumin leading to hypoalbuminemia, proteinuria of more than 3.5 grams a day, hyperlipidemia, renal vein thrombosis, edema due to the lack of oncotic pressure that we have. We've got our edema, thromboembolism, infection, and coagulability. We can also get ascites and pleural effusions as well. We don't usually get pulmonary edema with nephrotic syndrome, and that's because the fluid going back into the blood vessels is not due to oncotic pressure in the alveoli. It's due to hydrostatic pressure, and that's not affected by the loss of the proteins. So we get pleural effusion and ascites as well. Can anyone think of why we might get sodium retention in nephrotic syndrome? Oops, can't seem to get the chat open. Sorry, guys.
Don't worry, I can tell you if anyone replies.
Okay. I will tell you then, because we have loss of volume, intravascular volume, because we've become so edematous, our kidneys trigger the RAS system. So, and the RAS system obviously leads to sodium retention to try and increase our blood pressure because we've lost so much pressure from the loss of our proteins. So that's why we get sodium retention. And the hypoalbuminemia was due to loss of proteins and not being able to replace the loss adequately. Proteinuria, which we know about, the hyperlipidemia, which I spoke about as well, and thrombosis are also a complication. Increased risk of infections because we're losing all these proteins that are going to help us fight these infections, and increased coagulability. So how are we going to diagnose this? So we get a patient who comes in who's very edematous, has had, a 2-week history of, noticing increased edema, pitting edema, no other real background. So the easiest thing to do that is going to guide our diagnosis is to do a urine dip. So get them to pee and do a urine dip. And on our urine dip, we should see 3+ to 4+ proteins. So now we can see this proteinuria. There will be no hematuria, nothing else really will be seen. It will just be the proteinuria. And we will then take some blood tests. So this will guide us towards nephrotic syndrome initially, and then we must do, of course, blood tests to see what else is going on, because there are other causes of edema as well. So we have to rule things out. So we'll look at albumin, which will of course be low. We can see the renal profile. There usually isn't a disrupted kidney function unless it's leading to end-stage renal disease, but usually renal function is maintained. We'll also check our cholesterol levels and triglyceride levels, which will be increased. And we will look at serologies to find the cause. Why is this happening? Is it an autoimmune condition? Is it due to an underlying viral infection? We will also do ultrasonography to look at kidney structure and other imaging as well to see, is there a anatomical problem with the kidney itself? Is it enlarged? Is it shrunken? Just to see a fuller picture. And we can do a renal biopsy as well, because this diagnosis of exactly which type of nephrotic syndrome it is done by renal biopsy. Because although you might have noticed there are similar causes for a lot of them, the histopathology looks slightly different. The pathophysiology of it is slightly different, and how it's affecting the kidneys might be slightly different. So we then move on to management. So in all children, because it's always thought to be a minimal change disease unless proven otherwise, they all get steroid therapy. And a lot of nephrotic syndromes are treated with steroid therapy. You would have seen prednisolone in the management columns of all of them. So this is, we give 60 milligrams per meter squared once a day for 4 weeks. And then we do a weaning regimen. So we slowly decrease the prednisolone dose until they're at a level where they're on alternate days and then they can stop. We can also, if they can't have steroids for whatever reason, or the steroids are no longer effective, we can give them a monoclonal antibody as rituximab. If again the steroids are helping, but they're not completely taking away the symptoms, we can add in immunosuppressive therapy such as cyclophosphamide, cyclosporin, and things like that. And then we need to treat the symptoms as well. So they're hugely edematous. No one wants to be all podgy like that. So we would give them diuretics to help them lose all this extra fluid that they've been retaining. The statins to help with the hypercholesterolemia. And if it's diabetic nephropathy specifically, then we treat them with ACE inhibitors or angiotensin receptor blockers. So that is nephrotic syndrome. And we have different stagings of nephrotic syndrome. So once we have no proteinuria for 3 consecutive mornings, that child is then in, or that adult is then in remission. So they've, the nephrotic syndrome occurs in, as any kind of autoimmune condition might occur, it occurs in flares. So we have to control the flare, get them into remission. Sometimes they have relapses where the urine albumin goes back up to 3+ or 4+, and this has to occur for 3 consecutive mornings for it to be a relapse, and they have to have previously been in remission. So they've had no albumin in their urine, and then 3 mornings in a row they've got albumin in their urine. So then they need to go back onto their doses of prednisolone that helps with their management. There can be frequent relapses, so 2 or more relapses in 6 months or more than 4 in 12 months. We have steroid dependence, so 2 consecutive relapses while they're on alternate day therapies. So they take prednisolone one day and they don't the other. And sometimes this is maintenance therapy. So this is what keeps them in their remission. But if they're not achieving remission on that, they are steroid dependent, that they continuously need their steroids to stay in remission. Steroid resistance, so even if they're on daily therapy, they're still getting these symptoms and they're still getting urine in their protein in their urine. So this means it's resistant to steroids. So in this case, you would move on to your immunosuppressives or your monoclonal antibodies. And we have a congenital type of nephrotic syndrome that occurs as well, and this occurs within the first 3 months of life, and it's usually due to a genetic condition, but it's not very common. So that is nephrotic syndrome. Does anybody have any questions about that at the moment?
Yeah, there is one question. The question was, why is there increased coagulability in nephrotic syndrome?
Why is there increased coagulability? It does seem almost counterintuitive, but there is increased coagulability because we've got all of our blood flow becomes so we've lost all our proteins in our urine. We've not got as much pressure in our vessels because, again, we're quite edematous. So if you think of the triad, it's due to the stasis of the blood. So, you know, you have endothelial damage and you have hemostasis, and there's another one that contributes to the triad of coagulability. So this is due to the stasis, due to decreased volume. Does that answer your question?
Yeah, she said, yeah.
Yeah, fab. Okay, so let's move on to nephritic syndrome, and then I'll ask a question about a patient who comes in, and then you can try and decide whether it's nephritic or nephrotic syndrome. But this is nephritic syndrome with a capital I, and the I stands for inflammation. So what is nephritic syndrome? So it's a syndrome again, another syndrome. So it's a collection of symptoms that occur due to an underlying pathology due to different causes. So this nephritic syndrome presents as hematuria, so micro or macroscopic blood in the urine, elevated blood pressure, decreased urine output, so renal insufficiency, and edema. So they both have edema. That's the one thing that's joining these two syndromes together. And this is due to, again, an underlying pathology of inflammation ongoing in the glomerulus. So why do we think we get hematuria in nephritic syndrome, but not in nephrotic syndrome? And I will tell you why. It's because if you think about inflammation, we have a lot of vasodilation that occurs and our blood vessels become leaky. So if there's inflammation going on in the glomerulus, those blood vessels have become leaky and they are then going to seep in, then it's going to let red blood cells pass in through the filtrate into the urine. So that's where we get our hematuria from. So the pathology can be primary, isolated to the kidneys, or it can be a systemic disorder, and this is secondary. Another table to kind of break up. I like learning in tables because it puts all my information in one place. So that's why I've split it up like this. So the first cause of nephritic syndrome we will speak about is, the first one I'll speak about is acute proliferative glomerulonephritis. So this can be post-infectious, so after an infection, or it can be infection associated, so occur at the same time. So this is post-streptococcal glomerulonephritis. The GN stands for glomerulonephritis, is the most common type of glomerulonephritis in children. So this occurs after an infection with streptococcus, and this can be strep throat or impetigo, a skin infection. So if it's a throat infection, the glomerulonephritis will usually occur 10 days afterwards. And if it's strep throat, no, sorry. If it's strep throat, it will be 10 days afterwards. If it's impetigo, it will be 2 to 3 weeks after the infection. And the causative agent is group A beta hemolytic streptococcus. It can be infection associated, so different infections could be meningococcemia, staphylococcal infection, endocarditis, pneumococcal infections, hepatitis, mumps, HIV, varicella, EBV, toxoplasmosis, or malaria. So you can see that there are a lot of different infections that can lead to nephritic syndrome. So if we talk about just streptococcal, post-streptococcal glomerulonephritis, this occurs because of something called molecular mimicry. So the streptococcus bacteria has something called an M protein on it. And we have similar structured proteins in our kidneys and other places in the body. It can be the heart as well. But what happens is we make antibodies against the M protein antigen, but this can also has a similar structure to the proteins found in the kidney. So these antibodies that are supposed to fight the infection then go and fight our glomerulus. So what this leads to is immune complex deposition in and around the glomerular basement membrane. So if we've got immune complexes there, this is going to activate the inflammatory processes locally around and in the glomerulus. So we have, they deposit in and around the glomerular basement. We have activation of the complement cascade. Then we get T cells coming in, plasma cells coming in, and macrophages coming in. So this is all going to lead to a lot of inflammation in the glomerulus, and the coagulation cascade gets affected as well. And all this leads to increased permeability of the blood cells, the capillaries to let all these cells in, and then this all gets filtered into the blood, into the urine, sorry. And then this, that's just for the streptococcal, but a similar kind of pathophysiology occurs with these other infections as well. It's not due to molecular mimicry, but again, it's due to these inflammatory processes that are going on elsewhere in the body getting moved around the body and then attacking our kidneys. So to diagnose post-streptococcal glomerulonephritis, we can do something called ASO titers, which are anti-streptolysin O titers. And this just tells us that there was an infection going on by streptococcus that was ongoing, and that has led to this. So we just continue with a course of antibiotics, penicillin, or if the penicillin allergic, we give them erythromycin. And with the others, it's just about managing and treating the infection that's going on, and also managing and treating the symptoms that are occurring because of it. So another form of nephritic syndrome is rapidly progressive glomerulonephritis. So this can be due to many different things that are listed here. So we have anti-glomerular basement membrane antibodies, and this is known as Goodpasture syndrome. So this not only are these antibodies attacking our kidneys, but they also attack cells in the alveoli of the lungs. So we will have not only nephritic syndrome, but they can present with hemoptysis as well. We have lupus nephritis, again with SLE. Post-infectious can occur here as well. IgA nephropathy occurs. So where we have a lot of IgA immunoglobulins, and they go and attack our kidneys and lead to inflammation there. Henoch-Schönlein purpura, again occurring after an infection. This usually occurs in children. So this is a type of vasculitis that occurs after an ongoing infection that has occurred. So they come out in a palpable purpuric rash. And they also have symptoms of nephritic syndrome as well. Palsy immune associated with vasculitis. So this is a kind of autoimmune condition that occurs, and it leads to vasculitis, again, inflammation of the blood vessels, inflammation of the blood vessels specifically in the kidneys, in the glomerulus is going to lead to nephritic syndrome. So with these kind of conditions, with rapidly progressive glomerulonephritis, we have HLA alleles which are associated. So we have DR14 and DR4. In good pasture syndrome, we have the autoantibodies against collagen 4, and it's the non-collagenous portion of the collagen. So henoch-Schöllen purpura, HSP, usually occurs after upper respiratory tract infection. So we have IgA antibodies that go into the mesangium. It leads to cellular proliferation and white blood cell recruitment. And we have also ANCA antibodies occur, which is associated with autoimmune dysfunction and systemic vasculitis. So we get our symptoms, and then we have to find out why this is occurring and find out our cause and treat our cause. So to diagnose it, we will obviously do our urine dip, which will give us hematuria, some proteinuria as well. A patient will be hypertensive, and we will then have to go in and do further investigations, so in the form of blood tests. So we will look for autoantibodies, like the glomerular basement membrane antibodies. We'll look at complement levels as well. We'll look at some history of hepatitis. We can also do serum protein electrophoresis to look out for the SLE, and rheumatoid factor also. So in terms of nephritic syndrome, we are giving corticosteroids like we did in nephrotic syndrome, and again we're treating the symptoms that occur. So we give them antihypertensives to help with the hypertension, diuretics to help with the edema, and if the rapidly progressing glomerulonephritis can, if untreated, lead to renal dysfunction and end-stage renal disease, and if this occurs, then the patient will require dialysis. Okay, so how does nephritic syndrome manifest? So we have, in the morning, they'll have periorbital edema because they've been lying down and we've got edema of our face. And then as the day goes on, this edema becomes pedal edema. So we can see it on our ankles, and it will always be pitting edema. We also have hematuria. This can be micro or macroscopic. It's usually macroscopic, and it will be a Coca-Cola colored urine. And when we put it under the microscope, we'll see 3 red blood cells in a high power field. Proteinuria, but not as severe as we saw in nephrotic syndrome. Hypertension, renal insufficiency. So we'll see a decrease in the urine output as a liguria. And again, in good pasture or Wegener's granulomatosis, which is a type of vasculitis, we get hemoptysis and dyspnea. So when we see our patient, they might look pale, anemic. We'll take their blood pressure and it's going to be raised. They're going to look a bit overloaded. They'll have some edema. Their jugular vein might be a bit distended. If it's good pastures or Wegener's, if we have a listen to their lungs, we might hear some crackles, which is also going to tell us that there's some fluid buildup in the lungs. It can be a new heart murmur, so this will tell us that there's endocarditis going on. And like I said earlier, with the post-streptococcal, with the molecular mimicry, the M protein has it also has a similar protein in the heart. So that's what would lead to the endocarditis, and the palpable purpura might be seen in SLE or HSP as well. So not only do we look at the urine dip, when we have to look at the clinical examination of the patient as well. And what we see, unlike nephrotic syndrome, we can delineate a lot easier what kind of nephritic syndrome it is, as opposed to with nephrotic syndrome, where there's not much else going on apart from the edema and the proteinuria. So we have a patient who comes in, a little case study, so then you can try and decide, is it nephritic or nephrotic syndrome? So we have a 8-year-old male patient who comes in, and the little boy is looking quite edematous. and he's coming to A&E, and what kind of things would you want to know just based on the edema and the age of the child? Is there anything specifically that you would want to ask from the history to help you decide which way you're going? And what is the first thing that you would do in terms of investigations to help you with your decision in which is it nephritic or nephrotic? So is there anything specifically that you would like to investigate? It's a very simple investigation that can be done within seconds, and this will already take you towards your diagnosis. And anything specific that you'd want to know from their history?
Someone's just suggested a urine dipstick.
Yep, a urine dipstick. So you dip their urine and we see mild proteinuria, about a 1+ to a 2+, and we see hematuria as well. It's cola-coloured urine. And on our dip, we can see red blood cells as well. So already this is kind of giving away which of the two it is. But is there anything else you'd want to specifically ask? So, okay, from this urine dip that you've seen, which one of the two do you think it is?
They're suggesting to ask for any kind of recent infections, any recent respiratory infections.
Fab, yes. So you ask him about his recent respiratory infections, and he said he had an upper respiratory tract infection a few days ago. And that should kind of take you to your kind of final, is it nephritic, is it nephrotic?
Yeah, but then people are saying nephritic. Someone suggested it could be IgA. Someone wants to know if there's any rashes.
Yeah, there's no rashes, but just the history of upper respiratory tract infection. Those of you who said nephritic, that's absolutely correct. It is nephritic syndrome. And he had a strep throat infection a few days ago, about a week to 10 days ago. So this would take you to your ultimate diagnosis of
Nephritic, people are saying.
Yeah, nephritic syndrome, and it would be the acute streptococcal, post-streptococcal glomerulonephritis. Fab, well done. So glad it makes a bit of sense. So then if we take a break from all this syndrome and we forget about it now, let's move on to our third discussion, which is polycystic kidney disease. Now, there's a lot more to this condition than I have written about because there's a few different types, but I've just spoken about autosomal dominant, so polycystic kidney disease. So this is a multisystemic and progressive disease that leads to cyst formations. The cysts then lead to kidney enlargement, and other organs can be involved, other organs being liver, pancreas, and spleen. Like I said already, it has an autosomal dominant inheritance pattern. So this means that it's not X or Y linked, it's going to occur in an equal distribution in male and female. So it's autosomal dominant, found in males and females equally. There's two genes that are involved, and that means there's two variants. So we have PKD1, which is the most common, and this is due to a kind of genetic mutation that occurs in 16p13.3. So chromosome 16, the segment p13.3, and this codes for polycystin 1, and this is the more severe type of polycystic kidney disease. And we also have PKD2, which occurs in 15% of the cases, and it codes for polycystin 2. So what are these? These are expressed on the cells in the kidneys, and they interact with each other, and they regulate the cell cycle and division of the cells, and also intracellular calcium transport. So polycystin 1 and 2 belong to transient receptor potential channels, and these are mechanical receptors that sense fluid flow through the tubules, and they transport intracellular calcium accordingly. So what they have found that is in polycystic kidney disease is they have an increased of the intracellular messengers, so CAMP and PKA, and this enhances cell proliferations of the cells that are derived from this genetic mutation. So the polycystic kidney disease cells get proliferated more and more and more, and it inhibits the normal kidney cortex to proliferate. So we have more and more cystic cells than we do normal cells. We also have reduced endothelial vasodilation, so there's reduction in nitric oxide synthase, and this leads to hypertension because there's no vasodilation that occurs, so we become hypertensive. So this manifests clinically as hypertension, and if we were to dip the urine, we may see microalbuminemia, proteinuria, and hematuria. We also have renal enlargement. Now this leads to a lot of our symptoms that we have. So this will lead to the pain, this will lead to the renal impairment, because it's not the kidney that's getting larger, it's the cysts themselves, and the cysts aren't functional. So if we've got enlargement of non-functional parts of the kidney, it's not going to be able to do its job as well as it would have. So this leads to the renal impairment. This can be seen as oliguria and eventually gets worse and worse. It can lead to formation of renal stones. So if we think about cysts and the way we get kidney stones, it will form in the same way because there's a lot of fluid that's there, and the fluid isn't just pure fluid. It has things that can crystallize, and then these then go on to form stones. We can have hemorrhage of the cysts, and we can get recurrent UTIs as well. So we take our history and examination. So they may come with flank pain, which would be the most common cause of them coming to the hospital. So they might have a lot of flank pain. And we take a full history examination, and it can only tell us so much. So we then go on to do our imaging. So we can do an MRI, a CT, or an ultrasound scan. And with this kind of condition, the older the person gets, the more cysts you'd expect them to have. So it's a progressive condition. So from the ages from about 15 to 29, you'd have 2 or more cysts in one kidney. From the ages of 30 to about 50, you have 2 or more cysts in each kidney. And by the time you're over 60, you should have 4 or more cysts in each kidney. And the way to confirm the diagnosis is through genetic testing to see exactly which type it is, because as I mentioned, there are other types. There's autosomal recessive pattern of inheritance. There's acquired polycystic kidney disease as well. So we need to do some genetic testing to figure out exactly which type of polycystic kidney disease this is. So management. So the patient may come in due to flank pain. So the flank pain is usually due to an ongoing infection that's occurring within the cyst or a UTI, due to the formation of the stone, or it can be due to mass effect as well. So if we have a really large cyst, it can, push onto other structures, and this can cause pain too. So if it's due to one large cyst, then we just aspirate the cyst. But if there's many cysts, then we can do a surgical fenestration of the cyst, which is basically just fill them in almost, remove them. And I think it's about putting in a kind of some kind of mechanism that stops the cysts to form again. We can have hemorrhage of the cysts as well. So this can be a self-limiting episode. And if it is, then they just need some bed rest, some analgesia, and increase their fluid intake to make sure that their kidneys are being flushed out well. If it's severe and the patient becomes hemodynamically unstable, this will require a transfusion and admission to hospital. So if we have a cyst and UTI, so we have to treat this immediately because the cysts are filled with fluid, and this can then lead to further infection of the upper urinary tract and the kidneys. And if the fever persists for 1 to 2 weeks after the antibiotic therapy, you have to drain the infected cyst. We have stone formation as well, and we treat that with potassium citrate, and the hypertension is treated with ACE inhibitors and angiotensin receptor blockers. So the complications, this can lead to end-stage renal disease, lead to hypertension. Again, like I said, other organs can become involved, and this can be the liver, so we can end up with a polycystic liver. We can have cerebral aneurysms, renal stones, and infections. And that is all I have about polycystic kidney disease. So again, there is a bit more information out there on it, but I thought for the purpose of this talk, it would be best just to do a little bit of an introduction into one of them. So now I'm going to speak about UTIs, and UTIs is one of the real easy ones in renal diseases, because I feel like nephrology can be quite tricky, but UTIs are very simple and easy, nice topic. So I thought I'd end in that with the information overload I did at the beginning, not just something quite quick and snappy. So UTI, so we have, it can be uncomplicated, so it's just a bacterial infection of the bladder and the lower urinary tract. Infection of the bladder is called cystitis. So if you were to test someone's urine with just a urine dip, the way you know that they have bacteria in there is due to positive nitrites, and that's because the bacteria breaks down things and releases nitrites due to their own kind of mechanism going on. The most common cause is E. coli. And just because if you dip their urine and you see the nitrites, doesn't mean that they have a UTI. They have bacteria, they have presence of bacteria in their urine, but they don't have the symptoms of a urinary tract infection. And those symptoms are dysuria, so pain on urination. We have increased frequency, so you're going to the toilet way more often. Hesitancy, so when you do sit down to go to the toilet, it doesn't, you have difficulty with initiating the voiding. Urgency, you feel like you need to go absolutely straight away. And some people in a bit more severe infections can present with hematuria as well. What else might you think, except from the nitrites, that you would see in a urine dip? What other thing that we look for in a urine dip? What else might we see in there if there's an infection going on?
Some people have suggested leukocytes, white blood cells.
Yeah, white blood cells, which is another thing we'll see. And if it goes untreated or treated, but the treatment isn't effective, it can lead to an upper urinary tract infection. So this is then involvement of the kidneys. This is known as pyelonephritis, and this can manifest with initially starting as a UTI and then progresses to have fevers, rigors, nausea, and back pain, also flank pain. One thing that, again, having graduated in Bulgaria, we got taught is to do the renal punch test, which I don't think we really do here, but it's basically you place your hand on the flank aspect and you kind of punch your hand, and this should kind of jiggle around the kidneys, and because there's an infection going on there, it kind of causes pain in that region. So that's a test that they do there, but I don't think they do in England. So again, like we spoke about, we will do a urine dip, we'll see our positive nitrites, we'll see our white blood cells, and we might see some red blood cells as well. So we always, in a hospital setting anyway, if there is a UTI, you treat them, but we also send out for a urinalysis. So we're going to send it out to get cultured and get sensitivities. So we're going to see what kind of infection is going on and what is this bacteria sensitive to. So a normal, uncomplicated, basic UTI is usually treated with nitrofurantoin, and it does the 5 to 7 day course, and it kind of works quite well. We can also use trimethoprim, penicillin, and then a lot of the children we use with severe urinary tract infections, we use cephalexin as well. So in terms of kind of prevalence, UTIs occur more often in females than they do in men, and this is because of the shorter ureter that we have. And if we get a UTI in a male, this is not just a simple UTI, it automatically gets classed as a complicated UTI, and you have to do further investigations to find the cause. And it could be signs of STIs and things like that as well. And I think that is all I have. Again, it can become a pyelonephritis. When it becomes pyelonephritis, we have to move on to a stronger antibiotic with a slightly longer course. But again, with a good set of antibiotics, and if you do the course for however long is specified, 5 to 7 days, it usually is quite self-resolving and doesn't come with many complications. People who are at risk of UTIs, again, people are the elderly, again, women, and anyone who has a long-term indwelling catheter are at increased risk, and there are increased risk of a more kind of complicated UTI, kind of bacteria that won't occur. It's not usually due to E. coli, it can be due to a broader spectrum of bacterias. And that is all I have for you guys today.